What can you do if the bleeding just doesn't stop? Hi, it's Dr. Fan here. Let's talk about haemostatic agents. The best hemostasis is ligation. If a vessel is actively bleeding, it needs to be ligated. However, small vessels can be controlled by heat coagulation using energy devices or diathermy. See link below for more details. The operation is not complete until hemostasis is fully achieved. But what if there is a large area of generalized bloody ooze, such as on the liver bed? In these cases, the bleeding vessels are too tiny to ligate, and diathermy may not be sufficient. Well, this is where hemostatic agents can be useful. Hemostatic agents are used topically to treat bleeding surfaces. Their mechanisms of actions are either by physical, biological, or both. Physical hemostatic agents activate platelets and the extrinsic coagulation pathway on contact. They also provide a scaffold for thrombus deposition, absorb water, concentrate clotting factors, and tamponade bleeding. These include oxidized regenerated cellulose, collagen products, microporous polysaccharide spheres, bone wax, and other external agents. Oxidized regenerated cellulose products include Surgicell and Fibrillar. These are sterile mesh products that are absorbable over 14 days. They are most effective in areas of minimal bleeding. However, despite being absorbable, they are a potential nidus for infections and always look suspiciously similar to a gas-forming collection in post-operative CT imaging. Collagen products are porcine-derived collagen-based hydrocolloids. These include Gelfoam, Floseal, and Surgiflo. These need to be pre-mixed prior to administration and are injected over areas of bleeding. These agents are pH neutral, can be tailored to fit any area or shape, and can absorb 40 times their weight in fluid. However, again, being a foreign material, these have a risk of causing infections and fibrosis. Microporous polysaccharide spheres, such as Arista, are potato starch-based powders that absorb water to concentrate platelets. These are relatively cheap and fast absorbing. Bone wax, as the name suggests, is used primarily for bones. These are beeswax and paraffin-based products that cause direct occlusion on the vessels on bones. Other external agents include Quikclot, which is a kaolin-based dressing that activates factor 13. These were designed for military use but can be used in civilian settings. Biological agents augment the phases of hemostasis in terms of platelet plug formation and clotting propagation, termination, and fibrinolysis. These include tranexamic acid and other fibrin sealants. Tranexamic acid is a synthetic derivative of amino acid lysine. It causes reversible blockade of lysine binding sites on plasminogen. This inhibits the effects of plasminogen on initiating fibrinolysis. It can thus be used intravenously or topically to inhibit fibrinolysis. Other topical fibrin sealants exist that contain a combination of the multiple components required in the clotting cascade, such as fibrinogen, factor 12, thrombin, and calcium. Examples of these include topical thrombin and Tisseel. Of course, there are tissue sealants that combine the physical and biological properties of hemostatic agents to increase their effectiveness. These include Tachosil, which both include fibrinogen and thrombin coated on a collagen sponge. The collagen sponge offers physical tamponade whilst the biological agents enhance the clotting cascade. Whilst hemostatic agents are useful in helping achieve intraoperative hemostasis, they do have risks and can cause air emboli, anaphylaxis, infections, impaired wound healing, and vascular thrombosis. Therefore, it is always important to use these agents judiciously. And remember, hemostatic agents are no replacement for mechanical ligation of vessels. Thank you for watching. If you like this video, please like, subscribe, share and comment for more videos.